to let you know a little bit more about what we do at Queen Mary's University of London in global health, specifically in the Wolfson Institute of Population Health, which is where we work, and the Centre for Public Health and Policy. So we have a number of global health programs which we run. We run the online master's degree, and that's a 3-year program. You don't need to do it for 3 years if you want to do a diploma in global health. That would just take you 2 years. You just do the 8 modules that we run. You don't have to do the dissertation, or you can just do a 4-module certificate. We also do an intercalated global public health for medical students, and we do an on-site global public health and policy, which is you can either do that full-time or part-time. Full-time for 1 year, come to the university on campus. The online program, which is the program we're promoting today, is it's a 3-year program, and this is how it looks. So in the first year, you will do 4 modules. Second year, you'll do 4 modules, and then in the final year, you do your dissertation. The reason why we do 3 years rather than 2 is basically student feedback over the years. We've run this program for many years, so we have a lot of experience teaching global health online. But the feedback consistently has been, this is too intense for us students. We're part-time, we've got busy lives. It's difficult to do everything in 2 years. So we've taken that on board. And in keeping with the trend, I think that a lot of universities in the UK are doing, stretching it out to 3 years. So I guess the question is, okay, why would you want to come to Queen Mary's? And there are lots of reasons for doing that. It's a Russell Group university, which in the UK means it's in the top 20 or 30 universities in the country. So it's well known globally. We have some lots of awards in terms of recognizing gender equality, particularly in medicine. And the Faculty of Medicine and Dentistry recently was awarded Athena Swan Gold Award, which is like the top level award for recognizing its work in promoting gender equality in medicine. So the Wolfson Institute leads research on health inequalities in the UK. It does lots of work with its various centres within the institute. So our global public health unit, the Centre on Action on Salt and Obesity, and health and lifestyle research. So there's a lot of work that's being done. We're always in the news. So you have a lot of excellent research which informs our teaching. And our modules and our program is designed by cutting edge digital education technology. So we have a newly formed digital education studio that's working very closely to develop some really, really exciting cutting edge online content. I've been reviewing some today, and it's really amazing what they've been producing. So you'll be exposed to all of that if you come onto our program. So learning online, it's a new mode. It might be a new mode for some of you. I'm an online undergraduate, so I studied for 5 years online to do my undergraduate degree. So I have some understanding of how that is, but that was in the dinosaur age, and we've moved on tremendously since then. So you'll be learning on our own dedicated virtual learning platform, QM+. This is what it sort of looks like. This is on this slide. You get a snapshot of it. It's very easy to navigate, very intuitive, visually very interesting and exciting, and all of the content you can access through it. You'll have some lectures, some webinars, lots of online forums, so lots of opportunity to interact with your peers. You'll have dedicated office hours with your academic module lead, so you can contact them, meet them like you are with me now, one-to-one, and you can do that during their office hours. And the content is updated all the time. One of the exciting things about global health is that it's very contemporary. A lot of the things that you'll be discussing each week will be in the news, I can guarantee that. It's a very topical, very contemporary subject to be studying, so that you'll be debating and discussing and critiquing all of the issues that are going on in the world at the time. But you can study at your own pace. That's one of the great things about studying online is part-time. You can study at your own pace and you can fit it around your work and your life. And our students love that flexibility. And it's the main reason why they choose to study online. We always get asked this question, what can I do with my degree? Well, there's lots of things. We find that our students, they come to our program with a whole range of experiences and knowledge. So we don't see our students as empty vessels. We see them as coming and bringing something to the program. And our students like that as well, because they can learn. You can learn from each other. So we have students who are coming in from public health and all of these things that are listed on the slide. And then you can go on, if you want to, with your qualification to go into public health. Maybe one or two students might study at the postgraduate level, medicine. We find the civil service is a great area for employing graduates with global health degrees. You can go into industry. We've had students from various pharmaceutical industries joining us. Third sector is very, very common. You can go into jobs in charities, non-government organizations, and foundations, think tanks. Journalism, that's a really good area that you can branch out into. The BBC only last week was advertising for online journalists in global health. And academia, some of our students do go on to study for a PhD. So if you do want to apply, and I really hope that you do, and I'm sure once you've listened to Lola speaking, you'll be signing up immediately, which is great. If you do want to, then there are some links here. We'll also put an email in the chat if you want to just drop us an email. We can answer any questions that way or direct you to where you need to go in order to join our program in September. So I think those are my slides, but you didn't come here to listen to me. You came here to listen to Professor Oyinlola Oyebode, who is our centre lead. So Centre for Public Health and Policy. Lola is our centre lead. And I'm delighted that she's agreed to speak to us today on the topic of non-communicable diseases in very deprived urban neighbourhoods, which I know is her expert area. So I'm sure you're going to get a really fascinating and interesting presentation. There will be time for questions, Q&A, either on the presentation or also on any questions you might have about studying with us at Queen Mary's. But that's going to come afterwards. So for now, let me hand you over to Lola, who will be presenting on this topic. Thank you, Lola.
Thank you, Andrew, and thank you to all of you who've joined us. It's really nice to see you. Hopefully, maybe see you again after this on one of the master's programmes. So I'm going to talk today about non-communicable diseases in very deprived urban neighbourhoods. And I was introduced as Professor Oyinlola Oyebode, but you will also have heard that Andrew called me Lola, so I'm known as Lola. And what I thought I would cover today is just tell you really a very, very brief introduction to me, and then talk about what are deprived urban neighbourhoods, and then look at what the evidence is about non-communicable diseases or NCDs in deprived urban neighbourhoods. What are the drivers of NCDs in deprived urban neighbourhoods? And finally, have a closer look at some of the diet-related non-communicable diseases in deprived urban neighbourhoods. I will be also possibly asking for a little bit of audience participation in the middle, but we'll see if you if you'd like to take part there. So yeah, starting off with the introduction to me. So I have a natural sciences background. I started off in labs doing lab work, but then realised that what I really wanted to do was public health. And I actually trained in public health. So I did the Faculty of Public Health's training programme in the UK, which involves rotating around different organisations that do public health work. So for me, that was local authorities, the NHS. I worked at NICE and I worked in the health protection team. And I also did a little bit of academic work there. And that's when I decided I really wanted to do academic public health. And so since then, I have been working in universities. And I've developed expertise in three main areas. So first of all, the health of marginalised urban populations. Secondly, behavioural risk factors for non-communicable diseases, particularly diet. So there's also alcohol misuse, physical inactivity, and cigarette smoking, but I'm particularly interested in diet. And lastly, I really like to do work that is relevant to people in policy and in practice. So I'm also quite interested in research into how to bridge that gap between academic work that we do and actually making an impact on population health in the real world. Oh, there we go. And as Andrew mentioned, I lead the Centre for Public Health and Policy at Queen Mary, which is made up of 4 units. So we've got a unit that works on women's health. We have a unit, the Health and Lifestyle unit. We've got the Research and Action on Salt and Obesity unit, and we've got the Global Public Health unit. And the Global Public Health unit is the home of the MSc in Global Public Health and Policy and the MSc in Global Public Health, although Research and Action on Salt and Obesity unit do contribute public health nutrition module, and the Women's Health unit also contributes a module to that. Most of the academics who would teach you are housed in the Global Public Health unit. Okay, so now onto the academic content. So what do I mean by very deprived urban neighbourhoods? So here I've got a couple of definitions from UN agencies. So first of all, from UNESCO, a contiguous settlement where the inhabitants are characterised as having inadequate housing and basic services. And then here from UN Habitat, neighbourhoods that lack access to improved water, sanitation, sufficient living space, durable housing, and or secure tenure. So both of those really referring to, first of all, the fact that we're talking about a contiguous settlement or a neighbourhood, so we're talking about areas, and secondly, the inadequate housing and basic services, which are spelt out a little bit more in the second one, so specifically water, sanitation, living space, durable housing, so what's the house constructed, and secure tenure, which is often the root of some of these other issues, is the fact that this might be land that maybe the people living on the land don't have title or tenure to that land because they don't have those ownership rights. That's sometimes why some of these, like the housing, isn't durable, because you don't know. There's no point in improving your house if you might be bulldozed at any moment. And these sorts of neighbourhoods have got lots of other names. So, for example, slum, favela, bustee, informal settlements, shanty towns. Some of those might be familiar to you. And so, yes, I've quite often used the word slum in my research, although some people feel it is pejorative and so avoid it, which is why I'm kind of using very deprived or marginalised urban populations today. But you can see that the word slum is used, for example, by the UN. So in the Sustainable Development Goals, they refer to slums and in one of the targets. And also the word is used by people who live in slums. So SDI is Slum Dwellers International, and that is a global network of grassroots organisations made up of people who live in slums. So again, referring to slums in both their name and on the website, you can see. So there is kind of a tension around what terminology we use exactly, and I can see both sides of that argument, but today I'm mainly talking about very deprived urban neighbourhoods. So back in 2017, I was part of a group of authors who wrote a Lancet series on the health of people who live in slums. I'm going to tell you a little bit about what we said in that. So first of all, we highlighted that there are potentially 1 billion people living in slums, but there is very little, and at that time, very, very little health research on those populations. And that's for lots of reasons, including sometimes concerns about researcher safety. Then also there's high turnover of the population, which can make it very hard to do lots of different research designs. And also, as I mentioned about that kind of informal, so some slums are informal settlements where people don't have title or tenure to the land, and that can mean that they don't appear on formal sampling frames, so things like the census. And so where the census is used as the sampling frame for selecting people to take part in research studies, then these populations are often missing. And as well as there being very many people living in slums, the very little research that does exist suggests some very poor health outcomes in those populations. So there is actually a widely discussed urban advantage that people can believe exists. And often that's because of proximity to health services, for example. So they think, well, compared to rural inhabitants, urban inhabitants have easy access, relatively easy access to hospital services, for example. However, there is good data that actually when you do disaggregate that kind of urban population and look at the people who are in slums or in the very deprived neighbourhoods compared to the rest, then actually health outcomes are not much better than in rural areas, or potentially even worse. So in there you can see in the Nairobi line from 2012 and 13, this is looking at child mortality, and in the slums there's a rate of 80, which is higher than in the rural areas overall, which is 56 and 53 in the rural poor, and also higher than the urban overall. So actually there's some very, very poor health outcomes in these populations. In the papers, we also went a bit further on the definition of the slum, and we, as I said with those two definitions earlier on, the slum is a neighbourhood, it's an area, and that's quite important because there are actually some relatively rich people living in some slums. So there are reports of millionaires living in some of the slums in Delhi, for example, in India. But because of the neighbourhood they live in, there are still threats to their health. And these are neighbourhood effects, which are shown on this slide. So, for example, in terms of the physical environment, you can imagine that even if a specific household has got a toilet, if your neighbours don't have toilets, then your physical environment that your children are exposed to, that you're exposed to, that your parents are exposed to when they're visiting your house, that is going to be contaminated. So it's not so much about that individual's socioeconomic status, it's about the neighbourhood in which they live. And these other neighbourhood effects, so for example, the social interactions, so these can be very positive as well as negative, but of course the neighbourhoods can have particular characteristics, and everybody will be exposed to that no matter their personal circumstances. And there are often shared geographic hazards. So again, because of the way that these neighbourhoods form, they might form along a railway track, they might form in parts of the city that are vulnerable to flooding or to fires or to pollution from waste sites, for example. So often there are kind of shared geographical hazards because this is often land that people have come to and started to live in, but perhaps aren't a formal part of the city. And then there's also the institutional factors. So when you go to your health appointment and you give them your postcode or you give them your street or your neighbourhood, then potentially you're stigmatized because of where you've grown up, where you live. And so those things, again, it doesn't matter about the fact that you might have a university education, nothing about your own socioeconomic status matters. It's that postcode and what that represents. So finally, we suggested that the shared neighbourhoods where there are health risks which are concentrated could also be ideal settings for interventions that have the potential to benefit many people in a community at once. So yeah, that was really the kind of main thrust of that slum health series, was to say a lot of people live in these places. Health outcomes are really, really bad. When you look at the health research, it's not in any way proportional to both the size of the population and the health need there. And actually we need more research. We need to understand more about how to support better health in these areas. And on the back of that, I was part of an NIHR Global Health Research Unit on improving health in slums, which did work in Nigeria, Kenya, Pakistan and Bangladesh. And we did some geospatial mapping, some survey work, some evidence synthesis, some health economics to try and look at how to improve health in those neighbourhoods. And other projects that I've been working on include looking at sexual and reproductive health and rights of adolescent girls and young women living in some slums in Uganda, and also looking at climate-related risks and then COVID-19 risks in informal settlements in Africa. Okay, so that was a bit of an introduction to very deprived urban neighbourhoods, but now to talk a little bit about the evidence on non-communicable diseases in those neighbourhoods. So are NCDs important in very deprived urban neighbourhoods? So there's very little research. So as I said, there's very little research overall, but the research that does exist or did exist, certainly in about 2017 when we were at that series, was mainly focused on infectious diseases and maternal and child health. So there's really little research on non-communicable diseases. But there were lots of suggestions that, well, often the people who live in these neighbourhoods are young, because they're often people who've come from rural to urban areas to look for employment opportunities. So they're often kind of a younger population, a mobile population. And of course, non-communicable diseases become more and more important as you age. So maybe they weren't so important in these areas. And then there are also people who write, well, people who live in these areas, they're too poor to buy too much food. They're too poor to buy cigarettes and they're too poor to buy alcohol. And so some of these big behavioural risk factors are not important in this population. Oh yeah, and as I said already, that kind of focus on infectious diseases and maternal and child health. So that was kind of the picture at the point at which I started working in this area. Was we don't know very much about it, but we think it's probably not so important. But this is a very interesting study. It was published in 2015. The reference is there on the slide. But really what this study did was look carefully at studies of NCDs in low and middle income countries, and found that studies that relied on self-reported diagnoses to examine NCDs often found that socioeconomic inequalities were artifactually positive. That means that if you ask people, have you been diagnosed with diabetes, have you been diagnosed with hypertension, etc., then what you end up finding is that there are more diagnoses of those things in the richer people. However, when you look for symptom-based or criterion-based diagnoses, so when you actually, for example, take blood and check HbA1c, then you see that there's not that socioeconomic gradient. In fact, it's flat or negative. So probably the poorer people have got the bigger burden of disease. So this, again, was very important. It's around the same time as that Slum Health series, and really saying that, OK, you think that these people are too poor to smoke and too poor to eat too much, and so they don't have NCDs, and you think the NCD burden is with the richer people in these countries, but that's probably not the case. You only think that if you rely on self-reported. So do you have diabetes? That's because those people are getting better access to diagnosis. And yeah, this is a graph kind of showing the same thing, but I won't go into detail there. And then, so some work that I've done since then, and the paper is referenced at the top here. We did some evidence synthesis and tried to find all the studies that reported on hypertension and diabetes in slum populations. And we didn't find very many, but what we found prevalence that was reported of up to 50% of people having hypertension, up to 25% of people having type 2 diabetes. So actually, in some populations, quite high prevalence of these diseases. And when we had more than one study from the same country, so you can see we had 4 studies from Bangladesh, for example, 4 from Brazil, 22 from India, and we plotted them over time, we could see that it looks like there's an increase in the prevalence of diabetes and hypertension in these areas. And so then another piece of work kind of corroborating that is in partnership with Carter and the African Population and Health Research Centre. APHRC, that's the African Population and Health Research Centre, have a health and demographic surveillance site in Nairobi, which covers 2 slums, Virandani and Korogocho, in Nairobi, and they've collected a lot of data kind of monitoring the health of people who live in these 2 areas. And we did some analysis of that. I had a student who did some analysis of that data, and she looked at using the data that we had to tell what was the kind of cardiovascular risk of that population. And she found that most of the study participants seemed to have low risk. So 94.5% had a risk of less than 10% of a cardiovascular event over the next 10 years. But when she included the risk enhancing factors, which are things like abdominal obesity, then she found that actually that fell, and it was only 64% of people who had less than 10% 10-year risk. So again, depending on exactly what metrics you use, you can find that there are a lot of people who are at risk of cardiovascular disease living in deprived urban neighbourhoods. And then finally, it's just worth taking into account the social and economic impacts of non-communicable diseases. So there are obviously costs for hospitalisation in many low and middle income countries, which is where most people who live in these neighbourhoods are. Usually people have to pay out of pocket for hospitalisation, for medicine, for transportation to the hospitals. There's a time cost of people who are ill. You don't necessarily get sick pay, for example, and lots of people are working in the informal economy, so they don't get anything like that. If you're ill and you can't work, you won't make any money. And then there are often time costs for the informal caregivers. So if you're being cared for at home and that person can't work, again, they're losing that kind of on the day wage. People have to use their savings, and we can see that people are changing their consumption choices when they're ill because they can't afford the food that they would have wanted to afford. Then people don't necessarily, because you're working day to day and you can't take the time out to go to the doctor, then people don't get diagnosed, and being underdiagnosed leads to worse prognosis, usually more severe illness and bigger chance of disability, earlier mortality. And that can lead to loss of family members, loss of household income, which has consequences for family and consequences for society. So as I started off this section by saying that people thought, well, NCDs maybe aren't that important in these areas. And this is kind of to say, well, first of all, we think that there is an important prevalence of NCDs in these areas, but also the consequences here are so steep compared to for people who are in the higher socioeconomic groups, because the consequences are all of these things that we've described, usually underdiagnosis, worse prognosis, more severe illness, more disability, earlier mortality, and those consequences for family and for society. So even if there was half as much diabetes in those areas, I think the consequences are just so important. And that's why prevention, I think, is very, very important. Okay, so now we get to what drives non-communicable diseases in very deprived urban neighbourhoods. So this is where I was thinking that maybe people might have some thoughts and like to share them. I don't know. I think we've got a few of you on the call. So anybody got any thoughts about what factors they think might drive non-communicable diseases in very deprived urban neighbourhoods? If you've got an idea or two, feel free to unmute and shout it out. If nobody speaks, don't worry, but just want to give you a chance. You feeling shy? You want some encouragement, or okay? Shall I continue? Maybe I'll continue then. Okay, so yes, you could think about. I mean, I would have been very interested to know what you think might drive non-communicable diseases, but in the end, we'd often refer in public health to something a bit like this. This is one example, Dahlgren and Whitehead's kind of rainbow model of the determinants of health. So, you could start in the middle with age, sex and constitutional factors and think, well, as discussed, often the populations are quite young. And so maybe in that way, you'd think perhaps less at risk of NCDs. But we've also got the constitutional factors there, and some of you might have heard of Barker's hypothesis, which is the idea that if when you're in the uterus, you haven't had all the nourishment that you need, then actually later in life you can be more prone to some to cardiovascular disease, mainly more prone to putting on weight, more prone to metabolic dysfunction. So again, because of the population generally being more deprived, then you can imagine that some people might have that extra reason why they might be putting on weight. They might be putting on abdominal weight because of how the conditions that they had earlier. Then we've got the individual lifestyle factors next. So those are things like smoking, drinking, alcohol, and consuming a poor diet. So if you are food insecure, we know that you're potentially more likely to, when you do have money for food, buy higher, more calorific things, things that are higher in sugar, fat and salt. So in terms of the lifestyle factors, we could imagine that maybe there is poorer diet. If people are stressed, then maybe alcohol is a coping mechanism, cigarette smoking can be a coping mechanism. So yeah, there's potential for lifestyle factors to also drive some of this. And then we've got this kind of outer ring. So thinking about housing, healthcare services, we've talked about, although urban dwellers tend to have that proximity, there might be other reasons that reduce the access, particularly if you're in these very deprived urban neighbourhoods, because perhaps, you know, if you don't go to work that day, you won't get your wage. So you wait until you really can't work before you go and see a doctor. So you get kind of those late diagnoses. Got the water and sanitation, and there are links between infectious diseases and NCDs. So thinking about some of the things that might be waterborne and how that might cause make you more prone to inflammation, which could make you more prone to CVD, cardiovascular disease. We've got unemployment there, the work environment, often maybe dirty, dangerous, education, agriculture and food production. And then you've got the kind of wider socioeconomic, cultural and environmental conditions. So you could probably think about some drivers that lead to greater risk coming under all of these different determinants of health. Okay, so now I just want to take a closer look at diet-related non-communicable diseases in very deprived urban neighbourhoods, because this is my main area of research. And to do this, I'm using this framework by Turner et al. 2018. This is a framework of the food environment, just helping me to kind of categorise where this evidence lies. So first of all, looking at the availability, so the presence of food or products, and the accessibility of food in the very deprived urban neighbourhoods. I have recently completed a study with Rumaina Iqbal at Aga Khan University in Pakistan, and we did some mapping in an area called Azam Basti in Karachi, which is a very deprived urban neighbourhood. So we mapped all of the food vendors and spoke to them, and also residents, to talked a bit about the food that people found most popular, and ended up with a list of 34 ready-to-eat foods that were sold by vendors in this area. And when we sampled those and tested them in the lab, and found that 32 of them contained trans fats, which are fats that the WHO says we should not be consuming, and most governments are being asked to reduce their population's exposure to trans fats. But in this area, you can see that there was very, very high amounts of trans fats. And then we also saw that 21 of the 34 foods contained more than 20% of the daily fat intake, and 20 out of the 21 savoury foods assessed contained more than 20% of the daily salt intake. So in terms of that kind of availability and accessibility of food, you can see that the food that is on hand and available in areas like this are not really conducive to the best health. And then thinking about price and affordability, just showing you this graph, which is the cost of the Eat Lancet diet, which is like an optimal diet for both human health and planetary health. And this is showing you the cost of it as a percentage of daily mean household income per capita. And so what you can see is that in high income countries, it's quite a small percentage of our income per capita. But in low income countries, it could be more than 100% of our daily mean household income per capita. So what this is really saying is those healthy, these optimal diets are not affordable in some countries. And when you think that we're talking about the most deprived part of these population within those countries, then of course what people can afford is going to fall short of this kind of optimum diet. And then we've got the vendor and product properties and convenience. So here I just wanted, I mean, this isn't a very pretty slide, I'm sorry to say, a bit raw, but I just wanted to show you here that we've got this is data from that NIHR study I mentioned, so Nigeria, Kenya, Pakistan and Bangladesh. And we asked households, do they have a separate kitchen? And you can see here that people who said yes, so in Nigeria, we've got 37.8% of households who had a separate kitchen, and then 29.3%, and then in this one, 71.4%. But generally, they don't necessarily, these houses, they don't necessarily have a separate kitchen. And then the following question about the refrigerator, We also asked, do you have a refrigerator? And you can see that, not everybody. So in fact, in Kenya, in one of them, only 5% of people have a refrigerator. Again, this is just useful to think about, because when you think about the food that people are able to access and eat, I talked in that first bit about what was available, and this is ready to eat food sold on the street, and that's generally what people are buying. They're spending their money on ready to eat food on the street because they don't have the space to store food, they don't have the space to cook food. So it's all about convenience, and that means that this is a market that's really ripe for some of this really ultra processed food that is driving poor health. And I've also got the household for food security on there, which you can see is high, which, as I mentioned, when you have got a food insecure household, then when they do have the money to buy food, it kind of pushes people towards buying higher calorie, higher satiety food, which is, again, not the best for cardiovascular health or, yeah. And so, yes, finally, marketing regulation and desirability. So just a few pictures from Nigeria. You've got the pictures on the top. I mean, you see these adverts, they are absolutely flooding the cities. You can't go anywhere really without seeing adverts for sugar sweetened beverages. And in the top row, you've got pictures that you might imagine, these very large meals and sugar sweetened drinks. But in the bottom row, I also wanted to show the umbrella on the left and the umbrella on the right, and then this kind of Coca-Cola hoarding. So Coke and Pepsi, they seem to sponsor all the shops, and all the shops have this hoarding, which is kind of advertising Coke, or they've got these umbrellas outside their shops which are advertising Pepsi and Coke. So it's absolutely everywhere, encouraging people to drink these drinks, which we know are not very good for you at all. So now, coming to the conclusions, what I hope you've learned from this is that very deprived urban neighbourhoods are underrepresented in research, and very underrepresented on research in non-communicable diseases. However, non-communicable diseases do exist in these areas, and they're increasing, and their consequences are really dire. So it's really important that we do think about non-communicable diseases in these areas. There are many factors that drive non-communicable diseases in very deprived urban areas, and many very deprived urban neighbourhoods have got a food environment that drives poor diet, leading to diet-related non-communicable diseases. So I will stop there, but thank you very much for listening. It's really great. You've got my email address there in case you want to reach out. But of course, we'll pause now and let you ask questions. Both you can ask questions to me about the content, but you can also ask questions to Andrew about the courses. And it would be wonderful to see some of you on those courses next year. Thank you.
That's great. Thanks very much for that really excellent presentation. And let's see if there are any questions. You can either ask them orally or just put them in the chat if you want to. Anything at all about the presentation, or just about the online program, or the on-site program as well that we run.
Should I stop sharing my slides so we can see each other, or do you prefer them?
Yeah,
I'll stop sharing.
Nicola, no, I could see you were coming in and out. I hope you weren't having connection issues.
Yes, I'm sorry about that. I tried to turn the mic on and that was a disaster.
Oh, I see. Oh, were you going to tell me some factors that caused NCDs?
Well, I share my time in the Philippines and the UK, and in the Philippines, polished white rice is a major part of the diet. So that was where I was jumping in on.
Yeah. I mean, I've heard quite a lot.
Pollution.
Sorry.
Yes, we have such a lot of pollution.
Oh, pollution. Yes. Pollution. Yeah. Yeah, I mean, I did think about the kind of water pollution and the land pollution, because of being sometimes near dump sites, for example, but I think air pollution is really a big problem as well. And of course, I think across the world, it seems like the more deprived urban neighbourhoods are the ones that have the brunt of the air pollution, sometimes being on the side of the city that the wind blows the bad air over to, like the East End of London, for example. Yeah, thank you. And yeah, the polished white rice, I have been hearing about some sort of rice trade liberalisation in the Philippines, and also potentially pesticide use in the production of that rice. So yeah, I think yeah.
Case.
Thank you.
Yes, this is recorded, so I'll be able to catch up later, I hope.
Yes.
Great. Well, I'm glad you could make it, Nicola. Do we have any other questions? Mariana, go for it.
Hi, thank you so much both for your presentation. It's great, and I feel very honored to have heard your research. Thank you very much. My question is mostly around what Andrew presented. Currently, I work in the clinical world. I'm a physiotherapist for children, and recently developed an interest in global health and specifically physical activity in children with disabilities, and how this is affected by the inequalities, health inequalities, etc. So I've been trying to pursue a career around that and around global health and everything, and it's been quite difficult and challenging. And I've, as you may know, and I suppose my question has to do a lot with career progression. Having had a master's degree already myself, I realized that what it gave me was knowledge and personal development, but it didn't necessarily secure a career for me, let's say. So my question is, when you see all those students coming in and all these people coming in, do you see them competing with global markets, or, yeah?
Sure, that's a great question. And we were discussing it actually, possibly at our away day a few days ago, actually, in relation to jobs, and it's difficult. And some of the when we reflect on our own responsibilities here, we kind of think about whether we should be honest, with students coming onto the program about the job market and how easy or difficult it is. And there's no use pretending that the employers are starting to look at master's degrees as the entry point almost. If you don't even have a master's degree, then you're kind of going to struggle to make the grade, which is a crazy and sad situation to be in. So I guess students come onto the program for lots of reasons, but if they are students who are looking to either change the direction of their career, then they would choose a different degree like global health, because they see it as something which can help them pivot away from where they are at the moment. Or if they kind of know, look, I want to continue in global health, but I need to get up onto that next step, because if I don't, I'm really not going to be able to compete, to get into the kind of work that I want to get into. Lola was talking about the different kind of work experiences that she had when you were doing your training, right, for your public health training. And if you want to get into NICE, or if you want to get into some of the other public health organizations, I think they're going to expect at least a minimum of a master's degree. But yeah, we do need to be honest with ourselves, and students are always asking us for a kind of advice on what to do. And I mean, I kind of reflect on my own experiences. I mean, it took me a long time to get to where I am. I mean, and I've had many knockbacks. So I totally understand how it feels, and there's no guarantee. But generally, I find that the students who are, and I think this probably applied to myself as well, I was 100% determined to get to where I wanted to get. It was the only thing that I wanted to be. I've only ever wanted to be an academic since about the age of 9. And I was prepared to go through, fire and water to get there. And eventually I did, but it's a struggle. Let's not pretend it isn't.
I was going to add I think that outside the UK, so here we've got the Faculty of Public Health training programme that you can do to become a public health consultant. But in lots of the rest of the world, in most of the rest of the world, there isn't anything like that. So actually the Masters in Public Health or a Masters in Global Public Health, those would be, if you didn't want to work in the UK, then I think that's what most public health professionals have, and they don't have something further and beyond that. So maybe you might, if you're interested in global health and you're interested in maybe not being in the UK, then there might be more opportunities there. And then the other thing I wanted to add was that you said you're a physiotherapist. Yeah, so I'll put in the chat that we've got this HARP program. It is for health professionals, and that includes all health professionals, and it would include you as a physiotherapist. And I think I might have put the link to the PhD program, it says, but there's also a pre-PhD program. And if you want to work on global health and inequalities, then they would fund you either for a pre-doctoral year, which would be 1 year to do some research, or you can try to get PhD doctoral funding to do kind of 3 years. So that might be something that would be like a next step for you, having got a master's already, if you know already that you're interested in global health and you're interested in health inequalities.
Yeah, a colleague of mine is actually doing this with Queen Mary, I think. Yeah.
Good to hear.
I guess I would add that when you come onto a program like ours, you get the opportunity to network a little bit with your peers, because your peers are not coming straight out of school, they're coming straight out of a day's work, and you never know what kind of work they may be involved in, and so you might be able to tap into their networks, but also the academic networks. We're regularly promoting work, job opportunities. We have a couple of students who are joining me and another colleague at the World Health Assembly in Geneva next week, and they've been able to do that through our networks, and they will get exposed to some of the civil society organizations that are working in global health. So I guess there are it's kind of indirect and informal opportunities that you can kind of take advantage of when you're studying with us.
Yeah, thank you so much. I was actually, it's quite nice to be in a university again and network and share ideas always. It's always important. I suppose what I'm discussing is also a generational issue that's happening with with higher education. I think that the competition has gone next level, I would say. Yeah. Thank you so much.
Great, you're welcome. Thanks for the question.
Anyone else got any questions?
Doesn't look like it. Well, that's okay. If you do want to get in touch with us, Louise has put the email. This is our kind of Global Health Online admissions, administration email. So if you've got any questions that you want to ask specifically about the program, we can either answer them directly via the email, or we can point you in the right direction to where you need to go if you want to apply and you're not quite sure how to do that. So thank you for coming. Thank you for presenting, Lola. That's is very interesting. I'm going to follow up with lots of questions about that. So thank you for that. Thank you for coming, everybody. I hope that was useful, and I very much hope that it's whetted your appetite for global health and that you'll come and join us in the future. But thanks very much for coming.
Thank you.
Goodbye.
Bye-bye. Great.
Oh my
thanks.
God. 2 more people to go.
Brian. Brian, you're still with us, and
Titilope.
Titilope is still with us. I don't know whether they are. You still with us? I know they're going.
Oh, do we need to stop the recording? Oh, do you think Louisa stopped it? No, it's still recording.
Looks like Louisa's gone as well. I can't stop that, but I think it'll go.
I can. I've stopped it. I mean, she can cut off the end anyway.